So welcome to this webinar, everybody. My name is Catherine Pettis. I am the Senior Advocacy and Partnerships Officer for the International Association for Hospice and Palliative Care. I'd like to thank the World Health Organization for co-hosting this webinar with us, and you'll learn about their iSupport tools in the panel that's to come. So just a few housekeeping bits and pieces before I introduce you to the International Association for Hospice and Palliative Care and the International Day of Care and Support. This presentation is being recorded and will be available on the IAHPC Vimeo channel for those who wish to review it later or who are unable to connect today live. Uploaded videos will have closed captions and translations to all the UN languages. If you have any questions or comments, please use the Q&A tool, which is at the base of the Zoom screen, and we'll try and get to them either live in the discussion of the panel presentation or online or later on email. So first of all, what is the IAHPC? We're a global membership organization with more than 1,400 members in 156 countries, as this map on our website shows, with red dots that can be clicked on to show our members in each country. The box on the right describes our legal status in the UN system that gives us the right to advocate at the international level in the UN system for the 86% of the global population that has no or inadequate access to services. Our WHO work plan as a non-state actor includes organizing 2 webinars this year on palliative care for persons with dementia. The first of those, which dealt with non-pharmaceutical clinical management, can be found on our website under the Courses tab and is available to members. And I'll put a link to that in the chat so you can check on that. So just so we all understand what palliative care is, this is the global IAHPC consensus definition of palliative care, which is built on the original WHO definition. Palliative care is the active, holistic care of individuals across all ages with serious health-related suffering due to severe illness, and especially those near the end of life. It aims to improve the quality of life of patients, their families, and their caregivers. And you can read the full definition again on our website. This is the link, or follow the QR code because there's more substance there. Remember, this meeting is recorded and you can access all those slides essentially on the IAHPC Vimeo channel. So first of all, what's the International Day of Care and Support? This webinar is the IAHPC way of celebrating the International Day of Care and Support, which actually fell yesterday. But since there were several UN events yesterday, we're planning to do it today. So this is a relatively new, it's 3 years old, UN Day that recognizes and values the priceless care work, both paid and unpaid, done by millions of people, mostly women and girls all over the world. It promotes the idea that investing in care systems is crucial for gender equality and human rights. And today we're really thinking of those affected by Hurricane Melissa in the Caribbean and wondering how caregivers cope with such traumatic weather events. And this is why WHO and IAHPC are tackling this issue. Alzheimer's International released these infographics recently, which show the urgency, which is first, someone in the world develops dementia every 3 seconds. There are over 55 million people worldwide living with dementia. In 2020, there were. This number will almost double every 20 years, reaching 78 million in 2030. and 139 million in 2050. Much of the increase will be in developing countries that do not yet have services. So now, very briefly, I'm going to introduce you to our moderator, Dr. Victoria Hewitt, who's a palliative care physician, IAHPC board member, and she will be moderating the discussion that's to come, and the panel, which includes Laura Diaz-Garcia, who is a WHO consultant who will be presenting the iSupport tool of the WHO Brain Health Division. Peach Watanavitikul, who is from Thailand. She's a researcher and a carer of her mother. Dr. Joy Onario, PhD from Uganda, who's a clinical psychologist. And last but not least, Dr. Julian Abel, who's a retired hospice doctor and founder of Compassionate Communities UK. So I am going to stop sharing my screen and hand the floor now to Dr. Victoria Hewitt. Victoria, you have the floor.
And thank you, Catherine, for that. I have a bit of a personal interest in this particular subject, and I'll start by maybe explaining that so that you can understand why I think that this is so important. And I'd also like to give you the opportunity and encourage you to use the emojis and reactions that you'll find at the bottom of the screen to show us all how you're feeling today, if that feels comfortable with you. So feel free to do that right now if you would like. So, as I said, I am a UK-based medical doctor specialising in palliative care, and I've got expertise in healthcare quality improvement and project management. But for me, the subject of caregiving support for people with dementia is personal. And it started really in my childhood. All I can remember of my grandfather is that he was a very gentle man who was not like other people's grandpas. I didn't understand what Alzheimer's or dementia meant, but I knew how much my family loved him, and so I loved him too. What I also saw was that my granny, who was an extremely resourceful woman, was often exhausted. And as a child, I noticed she was sometimes very sad. I watched her dress, bathe, and feed him, and I knew at that young age that she needed a lot of help. I was about 7 when I was taken into hospital to see my grandpa, and I remembered the doctors taking my father and my granny into a little room, and then my dad telling me that grandpa was very sick and that he would die soon. And when I think back, I can remember feeling very confused. First of all, how did the doctors know that this was going to happen? But I can also recall a feeling of really being cared for. And the best way that I can describe it was that it felt like the doctors and nurses had put a warm blanket around us all. And that was a real lasting memory for me, that at that moment there was a lot of kindness and compassion shown to us. My father said he seems to think that was when I decided to be a doctor, but I'm not so sure. I think that was when I decided that I wanted to care for people. So today I'm joined by a panel of people who are dedicated to the holistic and dignified care of people living with dementia and their caregivers throughout their dementia journey, and including into palliative care. I'm going to start with Laura Garcia. Laura is an occupational therapist. She's a researcher, and she's a consultant with a passion for turning knowledge into action. Her work focuses on enhancing dementia care, aging services, and community well-being through knowledge translation, co-designed tools, and strategic partnerships. Laura, you've been working on dementia issues for more than a decade, and you now consult with the WHO's Brain Health Division. Please tell our global audience about the iSupport program, how the program can support caregivers throughout the dementia journey, and about the different formats that the program is available in order to ensure global access.
Thank you so much, Victoria, for that introduction. And thank you everyone for joining us today. It's really nice seeing all the messages from everyone that's joining from all over the globe. I am currently joining you from Peru, and it's really a pleasure to be here today. I'm going to share my screen and I'll walk you through the iSupport tool. So as Victoria mentioned, today I'm going to set the ground and introduce you to WHO's iSupport initiative, which was developed to support dementia carers globally. And I'm going to just give you a high-level overview of this tool, and we'll have really great panelists following my presentation that will go further into how this can be used in everyday care and support. Just to set the stage, I'm going to start by providing you an overview of the Global Action Plan on the Public Health Response to Dementia, which is the plan that guides all the work that we do at the WHO. And I'm happy to share that this plan was recently extended until 2031. The goal of the plan is to improve the lives of people with dementia, their carers, and families, while decreasing the negative impact on dementia on them, as well as on communities and countries. In the plan, you will find 7 strategic areas, including caring for caregivers of people living with dementia. A very important goal that we have in the plan is to have 75% of member states providing training and support for carers. Unfortunately, from the data that we have been collecting, we know that we are far behind from reaching this target, meaning that a lot of caregivers around the world that currently don't have the access to services that they need to support them in their role, but also to support their own well-being. As many of you on the call probably know, dementia carers need financial, social, and psychological support. But unfortunately, access to care support is still quite limited globally. Most care support provided is in high-income countries, and we know that only about 17% of low and middle income countries have carer training in rural and remote areas. This means that there's a lot of caregivers that currently don't have access to tools and services to help them in their role. Carers also need to be directed to the available support and encouraged to use it. So it's not only enough to have that support available, but also making sure that they're being encouraged to use that support and showing why using that support is important. We know that general practitioners and healthcare providers can play a really important role in promoting care services. So for any healthcare providers on the call today, I'm happy to have you here, and I hope that this tool is something that you can have in your toolkit to share with the people that you're supporting. So now I'm going to talk a little bit about iSupport. This is a project that was developed with partners from across the world. And the aim of the program is to provide knowledge and skills training for caregivers of people with dementia to prevent and/or decrease mental and physical health problems and to improve quality of life. The program is based on WHO's MHGAP guidelines and is deeply grounded in cognitive behavioral therapy, including psychoeducation, relaxation training, cognitive reframing, behavioral analysis, behavioral activation, and problem solving. So just a little bit of background information of what the program looks like. There is 5 modules for a total of 23 lessons. And this program is meant to be self-directed, so caregivers can choose any lesson that they might need at that time, acknowledging that people will come to the program at different stages in the caregiver journey, and that throughout that journey, they might want to go back to different lessons depending on the need or the education needs that they have at that particular time. Every lesson consists of an overview, examples, and interactive exercises to convey the main learning content and to check their understanding. And for the purposes of today's webinar, which is on palliative care, I'm just going to focus on a few lessons just to highlight how this program can be used throughout the entire care journey. I'm going to start by giving you an overview of Module 2, which is all about being a carer. You'll see that there's 4 lessons in this module, and for the purpose of today's talk, I want to focus on lesson number 4, which is involving others. We know that for many of us in the call, it can be really difficult to ask for help, and caregivers have shared that with us as well. It oftentimes, because there could be cultural expectations, familiar expectations, or social expectations that make it even more difficult to ask for help, even if we really need it. So this lesson walks the caregiver through different ways and strategies for asking for help, why it is important to ask for help, and different types of help that they can ask for. So as an example, I have here practical help that they could ask for, help with pleasant activities, emotional support, and providing information. Just reflecting back on some of the statistics that I just shared, because we know that a lot of caregivers don't have access to services that they may need. Relying on that community and leveraging on the support that they have around them is really important throughout the entire care journey. And that's why it's important to start building those tools and relying on the people that are around them to form that circle of care, not only around the person living with dementia, but also around the caregiver. And module 3 is all about caring for me, meaning caring for the caregiver, him or herself. And there's 3 lessons in this module. Lesson about reducing stress in everyday life, making time for pleasant activities, and thinking differently. Something that we hear about from caregivers often is that they just don't have the time for themselves. They're either caring for the person, they might be working, there just might be other things in their life, meaning that they're oftentimes, by the end of the day, haven't taken the time to look after their own well-being. Throughout this module, there's a lot of exercises that were selected because they don't take a lot of time, but can have a very long-lasting impact throughout the carer's day. And each exercise, I just have an example of one of them here, which it's mindful breathing. The module walks the caregiver through the exercise and approximately how long it will take for them to complete it. And there's also a lesson on thinking differently and how we can change unhelpful thoughts to also shift the way we're going through our day. There's many different formats in which iSupport is available, taking into account that not everyone will have access to the internet or to a computer. There's a hard copy manual that can be printed off, an online training. So the online training, anyone can access the modules, and again, they can access whichever lesson and module that they would like to access. We have iSupport Lite, which are quick reference posters. So these posters have the very key messages from each of the modules. And thinking about, for example, healthcare providers that may have a space in their clinic to put up a poster, this is a good idea to do that. But also for caregivers, if they just want a quick reference of the key takeaways from the modules, this is something else that they can quickly look at. For Dementia, this is a guide to leverage on technological advances such as mobile apps and technology to include caregiver support. And there's also short practical videos. Knowing that this is a program and tool that can be accessed from all over the world, I just want to highlight that it is available in different pictures and different imagery is available to make sure it is culturally appropriate for different groups. And I'm just going to quickly go over the impact of iSupport. And this is based on the generic English and the generic Spanish version. This particular slide here is on the generic Spanish version, and I want to highlight that this particular version, about 50% of users are actually healthcare providers. So for anyone on the call who's a healthcare provider and trying to figure out whether or not this tool would actually be helpful to you, from 75% of users strongly agree that the course content is relevant for building skills and/or professional growth. So we know that it can help both caregivers of people living with dementia and healthcare providers. And these are some statistics from the generic English course. When we ask caregivers that have completed the program whether iSupport improved any of the following symptoms, you'll see that a majority reported that it supported or improved their confidence. It improved their relationship with the person that they care for, stress, and then to a lesser extent, some reported that it helped with feelings of depression and anxiety. I also want to take this opportunity to highlight the amazing work of our international iSupport network. So this is a network of researchers and implementers from around the world that are currently working on translating and culturally adapting iSupport so that it can be used globally. Right now, the network covers 57 countries and 37 languages. And although not all of these adaptations are available for use yet, in this slide, you'll see all of the available versions that we do have. And I have the QR code there so you can access them. And you'll see that we have various languages available for the virtual course, the hard copy manual, and iSupport Lite, which are the posters. I want to end my presentation today by just highlighting another tool that you might find helpful. This is our Global Dementia Observatory Knowledge Exchange platform. And this is a platform where we have resources from around the world to address those 7 strategic areas from the Global Action Plan. So there are some resources for caregivers there. All of the resources that we include in the platform have been reviewed by our peer review network, which includes clinicians, researchers, policymakers, and also we have people living with dementia that have reviewed these resources to ensure relevancy, but also high quality. I thank you so much for joining us today. It's really a pleasure to be here, and I look forward to the panelist discussion and to answering any questions that you may have.
Thank you, Laura. Thank you for that comprehensive and really informative presentation. And I just want to remind the audience that you can post your questions, please. I invite you to post any questions in the Q&A section at the bottom of the screen. So I'd now like to move on to our next panelist, Mrs. Peach Watanavitikul. Apologies, Peach, if I got that wrong. Peach has been a dementia family carer for her mother since 2007. She's a coordinator at Alzheimer's Disease and Related Disorder Association Thailand, that's ADI Thailand, and is a research assistant at the Division of Geriatric Medicine in the Department of Internal Medicine at the Faculty of Medicine in Ramati Bodhi Hospital, which is in Mahidol University. So welcome, Peach.
Hi, everyone.
Hi. Hello.
So I have to say it's my pleasure to be here to share my story. Well,
Yeah. Well, thank you for joining us, Peach. We are very interested in learning about how your journey has evolved, especially as your mom's needs have shifted towards palliative care, and how your cultural background may have shaped your approach.
thank you. So I have to start to tell that actually my background was not the healthcare professional. I was an engineer, electrical engineer, and with the MBA degree. So most of my work in more than 20 years ago, mostly in the private company or some kind of family companies. And because I am the elderly daughter of the Thai Chinese families, so when there is something about the parents, the elderly daughter will be the one who take care and takes responsibility for it. Like, so after my mom got diagnosis, we have to adjust ourselves a lot. My family have 5 members, so actually we have one. My mom got dementia, right? And we have 4 carers. But these 4 carers, we try to cooperating, but we still fight to each other to take care of mom, right? So when my mom disease progressed more and more to the year 7, I think in that time, many of my father friends, family, they think it's a time I should leave my job to be the full-time carer. That I think that is not alive. I supposed to be. So, and what I'm going to do in the next 20 years after my mom passed away. So I will be like almost 60 with not being there. So I make a big decision to run the way to UK for another master degree in dementia studies with some support of my mom medical team, which is in Ramati Bodhi Hospital where I'm working for them now. So after I got the degree from UK, I back to work part-time with the ARDA and also taking care of mom with dad and my my brother and my sister. So we have so many things until my dad have some idea to use cannabis with mom. And then the BPSD got worse, and the head carer behind cannot stand, and she ran away. So finally, we have to move mom to the care home 6 years ago. So that is something that I don't know, maybe in Thailand, to move our parents to the care home is something that many people still feel guilty of that. But I think for me, maybe because when I was in UK, I worked at care home as a part-time carer as well. So I don't think care home is a kind of stigmatization of something. But I think if we cannot find somebody to take care of mom well at home, and in that time, mom lost some kinds of orientation. She didn't realize that she is at home anymore. And luckily, we find the nursing home that she feel like this is my home in the first day she moving in. So we think we just leave her with the professionals in the care home, right? And that can come to see her anytime. I can went to see her anytime. So that's okay for me. And then she lived quite well in the nursing home, and but unfortunately with some cannabis that still can believe that if you heal, but it's not healing, that make my mom getting worse. And then later she has been using the cannabis for a couple of years before COVID, but luckily that we got COVID and the nursing home shut down. And in that time I try to remove that all cannabis from her, and she condition getting better. Like her conscious came back or something, but unfortunately something in her brain already gone with the cannabis, and she started to got some kind of Parkinsonism symptom. It's like got some problem in movement, and after she got the first COVID, she cannot walk on her own anymore, and she become the bedridden about 2 or 3 years already.
Mhm.
So
So-
now, right.
Yeah, sorry, Peter. I was just going to ask you a question there. In your experience and those experiences that you had to navigate with your mum, what resources do you think would be helpful for caregivers to ensure that they've got the necessary training and support as their loved one's dementia progresses?
I think, and you're correct, that the knowledge is the most important thing that the carer need. But however, in Thailand, we got so lax of that kinds of information. We got the Alzheimer associations like the one I work here, and mostly the family will consult with their doctors. Okay, and I'm quite a lucky. I'm quite a lucky family that the doctor referred me to ARDA in those time, and I know ARDA, and then we got some trainings about care, about understanding dementia and how to live with mom, and how to communication is something that you see in iSupport thing. But however, in that time, I don't have iSupport from me. Then later, after I saw that iSupport already launched, and I think that, oh, this is the very good one. However, in Thailand, the language is still a barrier to get here. Anyway, in the same time that the WHO got iSupport, my team at the Mahidol University also got the grants to do the kind of a website to provide all the holistic care. And I a little bit compare that. Oh, okay, what I'm working on, it got the same content as iSupport, but they're
Yeah.
all in Thai. Right.
Yeah.
So now we got that website we call caregiverthai.com. So
Mhm.
it provides all like information about dementia care in Thai, but like actually it's everything that iSupport have, because I am the person who compare the iSupport content in both of them.
Oh,
Right.
well done. Excellent. So I've just got one more question before we move on to our next panelist. How do you take care of your own well-being whilst you're caring for someone with advanced dementia?
One thing I have been told that because the carers of the person with dementia, you have to take care of yourself first, because the person is relying on you, right? So if you let yourself down, don't keep yourself healthy, you cannot have enough energy to take care of them. It's just like when we are on the flight and we need some kind of oxygen mask, right? And we have to put ourselves first, then put to the one we taking care. It's the same thing. So that's what I encourage all the carer, that okay, you might not have much time, you have to take care of them, but you have to take care yourself first in order to take care of your people well.
Yeah, that's fantastic. Thank you. I'm sure there are people on this call who will appreciate that advice. And thank you, Peach, for sharing your valuable
You're welcome.
insights. Thank you.
Right.
Our next panelist is Dr. Joy Louise Honoria. Joy is a clinical psychologist and she's a lecturer at Makerere University College of Health Sciences. Her research includes psychological distress among family caregivers of individuals living with Alzheimer's disease in Uganda and demographic factors on dementia in older Ugandans. Her PhD thesis focused on the cultural adaptation of the WHO iSupport intervention for caregivers of older persons with Alzheimer's disease and related dementias in Uganda. Welcome, Joy.
Thank you so
Hello.
much, Victoria.
It's a pleasure. Thank you so much for joining us today. We're very interested in learning about the key adaptations you made to the iSupport programme for use in Uganda, including whether palliative care was discussed in your conversations with caregivers. Could you start by sharing with us about your PhD thesis and how you adapted iSupport for caregivers in Uganda?
Thank you so much, Victoria, for the question. I'll start with the adaptation part. So, you know, when we saw, my team and I, when we saw the need that caregivers had to have some information to know what exactly it is that they're doing. So we felt maybe we could start somewhere. We could start with iSupport. But before we went to the iSupport, we did some preliminary work of trying to understand, do they even know that they're managing dementia? Do they know what dementia is? So we went ahead to investigate that question to find out to them, what is dementia? What is Alzheimer's disease? What is Parkinson's disease to them? And then, of course, we also asked the question, so what have you been doing with all this? How are you managing? Because we believe they had something they were doing. They've been there. They've been with the patients for some time. And then that's when we now started selling to them the iSupport. So when we sold the iSupport, the way it is, the first thing we had was, you know, this is for people who are very educated. Not very many of our caregivers were educated. Actually, the demographics showed that majority of our caregivers had just about primary level of education. So they couldn't interface that well and engage very well with the iSupport tool as it is. So we realized we needed to do a translation into our local language for that particular region of Wachiso, which is Uganda, predominantly Luganda. And when we further did that, we showed them the different modules that are within iSupport, and all the caregivers were telling us we do not have the time to sit and go through a module the way it is. We would rather have it delivered as a group. So we said, oh, bingo. So then we can now tailor the iSupport to suit group sessions, which worked very well. So they allowed us to have 4 sessions with them, 1 session every week lasting 1.5 hours. And in there we compressed the 5 modules into 4 modules. And we now went into the nitty-gritties of the iSupport. some of the language needed to be broken down. Some of the examples were Western based, so we needed to bring them down to the Ugandan setting. We also needed to be very, very culturally sensitive as well as spiritually sensitive, because some certain phrases needed to be broken down for them to easily understand. And also the definition of dementia, we had to break it down. So back to what exactly did we adopt? We translated the language. We delivered it as a group format for 1.5 hours across 4 weeks. So we had one lesson lasting 1.5 hours per week for 4 weeks. And then we looked at the materials, the pictorial. They loved that so much, but we had to put in the local examples. For example, when you're talking about feeding options, we needed to use examples that they were familiar with. Things like matoke, those are bananas, plantain, millet, porridge, and all that, to look at the different feeding options. But then also the toilets, when it came to the toileting part, what we have, majority of the households we visited had, outdoor pit latrines. So we had to see how we can incorporate that in there and make it easy for them to understand, and also get photos and pictures of very acceptable, it was very feasible, and we did a pre and post test. So we tested for psychological distress, depression levels, symptomatology levels, and also quality of life. And after the intervention was delivered, interestingly, there was a reduction in the report of depressive symptoms, a reduction in the report of psychological distress, and a significant improvement in quality of life. And all these were actually statistically significant. But this was a pilot, and we were very excited with what we found out.
So that's amazing. And for those of us who work in palliative care, I guess we wouldn't be quite so surprised that you saw those improvements in quality of life and reduction in depression. What lessons that you've learned from adapting iSupport in Uganda do you think we can use to integrate palliative care into the dementia caregiver support program?
Oh, thank you so much, Victoria. The lessons are many, but let me, off the tip of my head, let me think about, I could talk about starting early. One of the greatest lessons that we learned was we need to start early, because globally we know that integrating palliative care into dementia care support works best when we start early. So from the very first contact that you have with the patient, with the patient's family, with the different caregivers, we need to normalize and, create the comfort and have value-based conversations that are going to clarify the goals of the caregiver, what the caregiver should anticipate, and we need to align this with the routines that the different families have. Because if I can go back to the group that we worked with, we were explicitly told, please don't have a training for us early in the morning. And also don't go past lunchtime. We don't have anyone, we're going to live with our patients. So we need a time where we're sure they have showered, they are well fed, we've changed them, and we have a bit of time for us to run away, and we can only give you 1 hour. So we need to incorporate all that in. But all this will come in if you start early, start the conversations early enough. But it's also important that we deliver the interventions that we have co-designed and radically simplified. The interventions as is are beautiful. They are very wonderfully written and they're lovely. However, we need to simplify them to be able to get to the grassroots as well, to the person who has never been to a classroom, to an individual who doesn't even know how to write their own name. We need to be able to design interventions that, that speak to them as well. So we need to translate into the local languages. We need to use the culture and faith sensitive narratives. We need to rely on pictorial step by step, but we also need to remember that there's something that the caregivers are doing. A good example is, I remember one of the caregiver telling me, when there are hallucinations and the person seems not to be letting go of the hallucinations, we sing to them. So we need to have some of those incorporated into whatever intervention that we need. But also we found that in order for us to reach more households, to reach more people, we need to use micro-learning across multiple channels. So we can talk, we can have the groups, we can do SMSs, we can do WhatsApp messages, name it, but we need to break them down into bite-sized components that everyone will be able to enjoy. Maybe I could also talk about the safety. So we need to build in elder abuse red flags, because that is something that came up. Simple caregiver safety plans. What happens to the caregiver? Yes, you are doing this. And many of our caregivers, at least for my country, many of them are not paid. They're family caregivers, and some of them did not even choose willingly to become caregivers. It just fell on them. You're the eldest child, you're the spouse, you're the sister, you have to give back, you're the granddaughter, you're the grandson. So what happens to you? Do you have a moment of yourself? How do you know that you need to take a break? How do you know that you need to ask someone else for support? So that is also very, very important. So, and finally, we need to measure what the families value. So what can we learn from the family? Do they value distress reduction? Do they value some kind of support? Because you'll find families, I found families that said, we need to buy diapers for our patient. However, we cannot afford diapers. So we have to make use of whatever it is we have available. We get bed sheets, wrap them into polythene bags so that they can retain a little bit more. So how can we have conversations? How can we partner with different NGOs, different people who are doing palliative work, but also who are doing caregivers and, dementia-related work, to see that we're able to have some of these basic necessities given to these families as well.
Thank you so much for those really illuminating insights. And I'm just thinking what you said there about how it adds value for the families as well, just echoing what Peach's experience that she told us. That's fantastic. And thank you so much for shining that light on that authentic application of iSupport in your context. I'm sure that the audience will have lots that they can take away from your experiences. And I'm sure we will have some questions regarding that later on. Thank you, Joy. Our
Thank you,
final
Richard.
no problem. Our final panelist is Professor Julian Abel. Now, Julian is the co-founder and director of Compassionate Communities UK. He's a retired palliative care clinician who became increasingly involved in finding ways of building compassionate communities around people at the end of life. He has run projects at local, regional, and national levels and served as Vice President of Public Health Palliative Care International. Julian publishes regularly on models of public health palliative care and is visiting professor at the University of Northumbria in Newcastle. Julian, welcome. Could you please share with the audience what exactly we mean by compassionate communities?
Okay, so yeah, well, delighted to be here. Sorry I was late. Thank you for inviting me, and what a great opportunity to speak to people all over the world. Fantastic. So, in a way, uh, the subject of dementia is kind of ideal demonstration of that because actually, when you think about the medical interventions um, which have a significant impact on the course of disease, they're few and far between, um, and often very expensive. So the bulk of what can be done for dementia is really about the caring network. And with the caring network, you then start saying, well, actually, what are the problems that the caring network faces? As we've already heard from Peach and Joy's description, is it actually because dementia can have such a long and protracted course that the impact that it may have on a single carer can be catastrophic in all sorts of ways. And when you start thinking about the social consequences of that caring, um, not just for the person with the illness, but for those who are looking after them, then you start thinking about um, isolation, loneliness, exhaustion, anxiety and depression, and all of the consequences which are familiar to people who can look after people with long-term illnesses. And when you look at it like that, you can then start to think about, well, what can we do about that? And then you think, well, okay, why don't we create supportive networks of resource? And then you start thinking about, right, okay, well, there's some stuff which is directly to do with the person with the illness, about making sure that they're supported, not just by the person, not just by the person that's closest to them, but thinking about all the other people who might come in and have a role to play. But then you're thinking about how do we support the people in the supportive network? And this is particularly important for the main carer. And then you think, okay, well, let's build a supportive network around the person who's doing the main caring so that they can do the things that make them feel human. Maybe it's going out for a drink, maybe it's talking to friends, maybe it's joining in community activities, maybe, going to a choir, which is an incredible place of support. Or maybe it's just having time out for yourself to go for a walk. And so you begin to see these ripples about how you build these communities of support. But the ripples don't just stop around the people who you might describe as being in the inner and outer network. You then start thinking about community and the civic sector. So how do you start preparing the community to look after people who are going through it? And we have to remember that 1% of the population die every year, and that 9 people on average are directly affected by that. That's 10% of the population every year who go through the experiences of death, dying, loss, and caregiving. And of course, for people with dementia, this might go on for many years. And you can think that the people who have been through it have developed what you might call death literacy, what you might call the knowledge and skills and familiarity to navigate through how to support people who are going through it in your community. But that doesn't just happen in communities, it happens in civic life as well. And the civic life is in our educational institutions, in our workplaces, in our places of worship, homeless people, museums and galleries, the list goes on and on. The 13 sectors of the Compassionate City Charter. So then the way that you can start thinking about this is, okay, we can build preparedness in our communities and in our civic life to look after people who are going through it, because after all, it's all of us all the time. It's up for the 90% to support the 10%. And so when we're building compassionate communities, we're building compassionate communities focused around the person with the illness, focused around the caregiver, focused around the people in the supportive network, focused around all of the civic spaces and community spaces they can go, so that we're ready, that we haven't forgot the ancient human activity of love and friendship, of care and connection. And that's what this is all about. And it includes the physical tasks of caring as well. That's not the only thing we're thinking about. So it's really thinking about social context and connections and relationships and belonging.
Thank you for that. And that resonates very much with my story and my experience with my own grandfather, that I shared at the beginning of this. In your experience, Julian, how can palliative care reorient itself in line with compassionate communities? And how do you think that will change both clinical practice and service delivery?
I mean, so this is a really central question, and a helpful resource for this, to thinking about how palliative care services can respond to this, is the Ottawa Charter, the 5 action points of the Ottawa Charter for health promotion. And these 5 action points are: 1 is building healthy public policy. 2 is creating supportive environments in the community. 3 is strengthening community action. 4 is developing personal skills in the community. And the 5 bit is reorienting health services towards prevention of illness and health promotion. So what this says is that, when we take into account the incredible biological impact of the positive impact of relationships, that if we want to promote health and well-being, that we have to build relationships in the community, and that we have to build the community capacity to look after people who are going through caring for someone with dementia or chronic serious illness, etc. We must make sure that our services don't have a negative impact. So a great example of this is the issue of manual handling. So if we say, okay, professional care needs to come in and deliver the professional care because it's the only safe way of doing manual handling, we create an impossible situation where we can't provide a population-based approach because there simply isn't sufficient resource, whether this is in resource-rich or resource-poor settings. The other option is to say, well, why don't we train community to do manual handling? Let's make sure that every single person who comes into contact with our services, their caring network has training in manual handling. And let's run education programs in the community for communities that want to help, want to support. And what this means is that rather than detracting from community by creating the conditions for help and support, is that we nourish community by delivering education, and we reorientate our services to make sure that we don't just step in and do service delivery. First of all, we build community capacity, and then we can step in for those people who really most need it. And that's reorientation of healthcare in the context of health promotion by building healthy communities, healthy community resource. And that's a big challenge for services who think that they are the knowledge holders.
Yeah. I think, yes, you're quite right there. And what I loved what you said in the previous question that you answered about how it's up for the 90% to support the 10%. I think that's that way, when you think of that in the context of a very medical model, and the amount of how can those health services as currently set up provide the 90%, providing the support for the 10%. I think that's something that we maybe all need to take away and think about. Thank you, Julian, for that. And thank you for to all of our panelists for sharing your experience and for answering the questions. We've learned so much today about the possibilities that are opened up by both iSupport and compassionate communities for people living with dementia and their caregivers. And we've had a lot of questions coming in. And as we approach the final segment of our 90 minutes together, it's time for us really to explore those questions. Katrin has been monitoring the Q&A section, but before I go over to her, I've got one question for all of our panelists. So if you wouldn't mind putting your cameras on, it's really a related question to all of the things that we've already discussed. And as Julian said, in many settings, caregivers of family members with dementia are typically only supported by family neighbours and their faith communities. So how might trained professionals be equipped to complement and strengthen this existing community-based care? In your experience, how can community and professional sources of support work best together to improve care for persons with dementia? I don't know if anyone wants to go first answering that question. Julian?
So a great starting point for this is to find out what it is that communities are interested in, because as my friend Cormac Russell says, when you know one community, you know one community. And it changes for every community. So the whole thing starts with a conversation about, okay, what is it in this community that people feel like is strong? And what are the community resources which are available? And you might call, the question about community resources treasure mapping. It's saying, what are the community treasures that are available that in ways in which community can support each other? And that's, places where people already meet. It's people who have already been through it and are experienced about it. And people with knowledge in the community. So you do your treasure mapping of the spaces where people meet. And then the next thing is, well, what else do you need? What can we do as services that will support you to do what you do brilliantly? And so it's making sure that you build relationships which are specific to that one community that you're working with, so that you can discover what would be most helpful to that community. And that means going in with humility and curiosity as your first step.
Yeah. And that really resonates with what you said, Joy, about really understanding that context in which to implement something like iSupport. Would you agree with that?
Yes, I do agree with that. And it's important. It's very, very, I cannot overemphasize this enough. It's very important for us to know what exactly does the community need.
Mm.
So we start with that question before we say, hey, this is what we have. It is important, of course, that we need to have, for example, standardized screening. We need to have, when to refer, where do we refer, when do we refer? But then is that what the community needs? And I believe if we're going to take iSupport forward, if we're going to take the palliative interventions forward, understanding the community and who you are working with and speaking to them at that level is what is going to enable us move this through.
Thank you, Jo. I can see Catherine has her hand up. Catherine?
Thanks, Victoria. And thank you, everyone, for the great presentations. I had a question for Julian, which was, Julian, you said, why don't we train community in manual handling? That was one of your rhetorical questions. And then let's run programs and let's do treasure mapping, all of which are brilliant ideas. But what I was wondering if you could clarify is who's the we and who has the agency in these initiatives that you are suggesting? Thanks.
There's these are the practices of community development, and you can approach that from the community setting. So you might be a community member who actually wants to just get involved and make things better, and you can use these principles to build compassionate communities. Great example of that, Compassionate Ottawa, is a group of citizens in Ottawa who came together to say, we want to do something about supporting the people in our community who are experiencing death, dying, loss, and caregiving. The drive might come from the civic sector, where there's a civic initiative to say, yes, we want to be a compassionate city. And that's a question of bringing civic leaders together, and from your educational institutions, from your religious institutions, from your workplaces, your chamber of commerce, or your local council, your mayor, whatever it is. And they may be interested in doing that, and then they use those. They're the people who have the we refers to those. You may be a palliative care service, and you may think, well, we're as a palliative care service. Sorry, this is the dogs having a fighting game right beside me. If you're hearing weird noises, that the palliative care services want to take a whole population approach, thinking that everyone who experiences death, dying, loss, and caregiving, they all have these social consequences, whether this is murder, suicide, accidents, sudden death, natural disasters, wars, as well as from chronic disease. And then you think, okay, well, we can do something about it. We're not powerless, that we can use these practice methods of public health palliative care to build the resources in the community, in the civic sector, and we can reorientate our services in line with that. So the driving force can come from different directions, but the key is when you know one community, you know one community. That what you do is not going. There is not a standard answer that fits everything. There is building relationships through curiosity and humility, and working with community strengths in the first instance, not community deficits. You want to know what's there, not what's absent. Does that answer your question,
Yeah,
Kathy?
it's brilliant. So theoretically, a palliative care association could do that. That would be one of the people with the agency to do that.
So, I got a great example of this. I gave a talk. There's a Compassionate Spaces program run by the Institute of Palliative Medicine in Kerala, which has been advancing public health palliative care in practice for 30 years. They're absolutely fantastic. I gave a talk at that, and somebody got in contact with me from Kenya, saying, I'm really interested to hear about this. I'm a retired community palliative care nurse, and I'd like to take this forward. What next? So I put her in contact with Mark. Mark Mwesiga, who runs a palliative care association in Kenya.
No, Uganda. He's the ED
in Uganda, rather.
Yeah.
Next door to Kenya. And Mark gave a fantastic reply to the person who got in contact and said, we respect and treasure what you're doing. And we've been running programs in Uganda for a while. And in particular, in a resource poor region where we can't afford professional care, this has been really dramatically helpful. So the answer, and Mark is the president of the Palliative Care Association of Uganda, and that they have the Palliative Care Association of Uganda has led that. So yes, it can be done everywhere and anywhere.
And just whilst we're in Uganda, there is a question which you may be able to answer, Joy, that's come up in the Q&As. And it says, in Uganda, what diagnostic tests are done to confirm dementia, and whether these were achieved for all of your beneficiaries, or you diagnose clinically, which is what is done in most African countries. Are you able to answer that? Oh, Joy, I think you're on mute.
Thank you.
There
Thank
we
you for
go.
the question. So particularly for the study that we conducted, we have a cohort, and the cohort is nested in a much bigger study called the READ ADSP. And for that particular cohort, we do an extensive assessment. We do the clinical exam by the neurologists, psychiatrists, clinical psychologists, but then we also have the psychometric tools. For example, we use the IDEA cognitive screening tool, which is the identification of dementia in elderly Africans. So we have, there's a tool that was developed. We have the community screening instrument for dementia that is also being used, and we also use the mini-cog, we have the MOCA. There are quite a number of psychometric tests that we use, and then we adjudicate the cases after we've been able to see who is dementia, who is not, who is Alzheimer's, who is Parkinson's. We sit together and compare notes with a team, and then determine from that team of 5 experts who actually is categorized as ADRD, Alzheimer's disease, and other dementias. So there are quite a number of tools that we used for this particular study. I cannot say so much about the clinical setting, but for my clinical setup, I've mainly used so much of the MOCA. I've used the mini-cog. Lately, I'm using the Alzheimer's Association tool for dementia screening as well.
It's really
I don't know
helpful.
whether
Thank you for answering that. Yeah, no, I think you have. There's also a really interesting post in the questions that I'm going to read out to you, and it's from Carol. And Carol says, I've been reading about Italy syndrome. I don't know if anyone's heard of that. It's a condition where carers primarily from Eastern Europe countries have moved to Italy to work as dementia caregivers, and they have become very ill after years of being away from their families, working 24/7, caring for people with dementia. This impacts not only the caregiver, but the children that are left behind, that are suffering mental health issues. And I think this is really important. It's a really important issue about the migration of the healthcare workforce. And I know WHO are also actively working in that particular area. But I guess I'm conscious that Peach, you moved away from your family as well. Is there anything that you want to add to this? Is this something that we need to maybe be more aware of? And specifically, Carol asks, how can we support this population?
I think in Thailand there may be some kinds of this issue as well, because most of the older people, pet carer now, come from abroad, from Burma, from Laos, and they also maybe got some kinds of program that we still have we have more welfare for them, but mostly it depends on the family or the employer to take care of each one. Like will allow them to go back home if they need or something like that. And from my experience, to have the Myanmar caregiver to take care of my mom in those times, well, because she came here to work in Thailand, she would like to work every day, do the overtime, and like 7 days, 24 7 working, right? But once I told her that you must have some break, because taking care of my mom with Alzheimer is not that easy, and she didn't believe me. But one day he got like a hyper like breathing so quickly, and got some symptoms that came from her stressfulness after taking care of my mom. And we have to took her to the hospital and have some rest. After that, she realized that on Sunday she has to leave the job to have a break from taking care of my mom. I think for about the workforce, we still have to work a lot with this issue.
Especially in as the world's population is is aging. I think this is something that
Yes.
we need to be much more aware of. So there's a couple more questions that have come into the Q&A. And one is about advanced care planning. Are there any models on advanced care planning related to dementia, especially those that can be co-created with families after a dementia diagnosis?
I can go ahead and answer that, Victoria.
Yeah.
Thank you so
Yeah.
much for that question. I think advanced care planning is something that needs to happen very early on in the trajectory. And as the person progresses with the condition, it's something that we always advocate for. And the importance of early diagnosis, I think, comes into play with this as well. And I'm going to add afterwards to the Q&A some papers that have been published in the past 2 years. So this is a topic that 2024 and 2025, there's been quite a lot of movement in relation to advanced care planning. And there was one paper that was published this year, specifically addressing this question of how can we co-create advanced care planning for the person living with dementia as they move throughout their journey. So not just at the beginning, but how can we start revising this advanced care planning with the person as they move. So I'll add those papers because I think they might be of interest and you might be able to find important information there. And there's something else I want to highlight because we also have a blueprint for dementia research where we have identified some gaps that we currently have in the dementia knowledge. And a lot of that has to do with models of care. So we do have a group right now that's working on kind of addressing some of the research gaps related to models of care. And there was a study again that came last year related to advanced care planning. And one of the things that they found is that there's right now a gap in models that we can actually implement in the community and that are co-created for people living with dementia. So in short, there are models that are being created. I can't think of any one that is kind of implemented right now that is being used widely. But this is a topic that has gained quite a lot of attention recently. And I know there's been some emphasis that has gone on to understand what advanced care planning looks like in the context of dementia, and acknowledging that just because you did it at the beginning doesn't mean that you just leave it there. You really do have to revise it as the person continues on with their disease, and finding ways to ensure that the person is actively engaged throughout that process is really important. And oftentimes what I've seen in families is that they get the advanced care planning at the beginning, but then it's not revised over time. So I think that's something that it's really important, and it's highlighted in your question. How can we ensure that we're co-developing this process with the person with dementia? So I'll add those links in the chat so you have access to them. And I'm hoping that in the future, we'll be able to have something more concrete to share with all of you. Thank you.
Thank you, Laura. That's really helpful. Yes, Julian.
So I think we've reframed advanced care planning because advanced care planning is actually a medically driven tool that aims to essentially try and determine where people want to be cared for. And certainly in the UK, that's been driven by a reduction in healthcare usage, to try and reduce healthcare costs by having people die out of hospital. It's a medically dominated question, and actually it needs to kind of go a lot way further back, and that we've started something called What Matters conversations, and that's about when you ask people about, okay, well, what matters to you most of all that will enable you to live well, and not just the person with the illness, but those surrounding them, and that you can make sure that your treatment goals are aligned with the things that are most meaningful to the person with the illness. And that may not be anything to do with where they're cared for and where they want to die. It may be other things completely, like I want to spend time with my animals or my cats or with my family, or actually I really like going out for walks in nature and that's most important for me. Or if you're thinking about indigenous communities, it's being in country, being on the land. And so if you have what matters conversations, you can then start to orientate about making sure that any care that's delivered is the most meaningful care to the person with the illness and those supporting networks around them. And then when it comes to the final bit answering about advanced care planning conversations, if you've had what matters conversations, the advanced care planning bit is really straightforward and easy because you have already figured out about what living well means, rather than where do you want to be cared for and where do you want to die. And the questions, the answering of those questions about where do you want to be cared for and where you want to die are contextualized in the living well side of it. And we got if you want to look up, we've got a website with all of this stuff on. Is whatmattersconversations.org that you can look at. We've got materials and examples, all that kind of stuff on there. That came out of a joint initiative between the Royal College of General Practitioners and the end of life. What do we call ourselves? It was convened during COVID, but it was an end of life group to try and figure out how to manage the difficult questions that were being answered at the time. End of life reference group, Royal College of Physicians, Royal College of General Practitioners, end of life reference group.
Perhaps you could share that link, and if we get that link, we'll share it with the participants, because I think that would be really helpful. I've got time for one more question. If you've posed a question and it hasn't been answered, we will answer it in due course. It's just we've got a lot of questions coming in. But I want to go to this one from Zini Lim. Can you share experiences in how a non-profit organization can help to advocate for caregivers to dementia? Does anybody have any advice that they can give about that? Rach, was that you? Yeah.
Because yes, because I'm from ADI Thailand, right? And I actually one of the caregiver that got advocated by the Alzheimer's Disease and Related Disorder Association, because this organization they try to because one thing is in Thailand, most of the person with dementia they were under the care of the family caregiver, right? So if we would like to support them, we have to support through the family caregiver. And the first time that I met my current medical team and they introduced me to ARDA, is the first time I really understand what dementia is, and like have a big picture of what I'm fighting with. And that's happened to many carer in Thailand now. And I think that's all over the world who most of the Alzheimer associations in their countries work with them as well.
Okay, that's great. I've got Catherine and Catherine, have we got time for one more question?
Absolutely. Yeah.
Okay,
definitely.
fabulous.
Yeah.
Fabulous. How to navigate caring when family members are not available due to distance and limited resources. So this is a question about it's quite a lot to aging neighbouring persons who have their own health challenges are limited in the support that can be rendered. Reaching governmental and civic support is also overburdened, and reaching reasonably affordable possible support poses serious challenges. What advice would you give to this person who's asked this question about how to navigate that?
So I think this is all about compassionate communities and compassionate cities. And you might think about this as the preparedness of communities to swing into action when people need help and support. So that's a kind of upstream. From a public health perspective, that's an upstream activity. That old thing about rescuing people from who are drowning in the water, and resuscitating them, and successfully or not. What you really want to do is stop people from jumping in the river in the first place. So that's upstream thinking. And that's about community development and compassionate communities. And that's about mobilizing communities of support in all of the different places that we've been speaking about. And that means building compassionate cities. You know, cities refers to citizenship rather than urban or metropolitan places to live. It happens in rural communities as well. And so that's building partnerships and building community readiness and using community networks so that people are supported in a way that's relevant to them. And that kind of applies to the caregivers as well, because everywhere in the world now has a multicultural setting, and building what works in one community, as we described, doesn't work in every community. So that's about, you know, that if you've got migrant support workers, then you do, okay, well, what does community building look like amongst those migrant communities? And that means going to those migrant communities, building relationships and finding richness of resource that is already there in those communities. People who are already skilled and knowledgeable and literate, and working with those communities to build resource so that when somebody is in the situation of needing help and support, the community is already prepared to do that, rather than thinking that you've got to make it all up on the spur of the moment.
Fantastic. That's yes, Catherine.
Yeah, I would also suggest to add to what Julian said and the other people have said, and I'd like to hear Joy and Peach's reflections on this too, is the role of faith communities in compassionate communities and supporting caregivers. The question about a distant caregiver and how would you do that? Because I think faith communities have a lot to offer, but I think they need to learn much more about palliative care, which is why we've started the Interfaith Advocacy Coalition to educate faith communities about palliative care so they can do exactly that. But I wonder what your experience is in Thailand and Uganda for that. And if the iSupport tool includes faith communities too, Laura. And then we can probably wind up. While I'm on, and I don't want to take any more time, could the webinar attendees who've stayed, please stay on to answer a brief survey when I close the webinar. So thank you, everybody who's attended and the panelists, and I'll take myself off, but please stay on for the survey.
It's an interesting question about the role of faith communities, most especially in situations where we don't have so much of family coming in to support. But even when there is family, because some of the people that I've interacted with, there comes a time when they're not able to continue providing that support. So this is where now the faith communities come in. And like you have mentioned, many of them have no idea. For example, when we started out asking the question, what do you know about dementia? What is actually dementia? It was interesting how many people felt it was a curse. You did it to appease the gods. So when we go now to the faith communities, if that is not demystified, then we are going to have a challenge on our hands where the care is going to be more in the line of exercising, praying. Okay, that shouldn't be a challenge, but if they're aware and they understand more of what needs to be done, because iSupport is based on the MH gap. So task shifting is very crucial, and training the faith leaders or faith-based organization in delivering some of these modules would also be very helpful in them coming in to support the families.
I'll just add to that, because that's exactly what I was thinking, Joy, just the importance of using these modules to train individuals that might be helping caregivers or might be helping people living with dementia. And it kind of is directed, associated with dementia inclusive societies, you know, making our societies dementia inclusive so that people are aware of what is dementia, are educated on dementia care, communication, the progression of dementia, you know, all of these elements are connected. And iSupport could be just one education tool that people can use to educate themselves about what is dementia, what are caregivers, what might they be feeling, what might they be going through, and then how can I use maybe some of the exercises that are mentioned in iSupport to help the caregiver go through those exercises, so they're not doing it alone, because it can be really overwhelming for someone just reading the exercise and being like, I don't know how to do that. But then if we have someone else that has taken the time to go through these modules, then they can be a partner in that care for the caregiver. So I think it is really important to ensure that education is at the forefront of a lot of this, and that includes empowering faith communities and leaders within those communities to be more educated on what the condition looks like and what they can do to better support both the caregiver but also the person living with dementia.
Thank you so much. So in the final 5 minutes that we have together, I'm going to hand back over to Catherine. Before I do so, I would like to say thank you to all of our panelists and to the audience and to all of those people who've asked really thought-provoking questions. It has been an absolute joy to moderate this session, and I look forward to working with you all again in the future. And not only that, but to seeing the world of possibility that we can create and that we can step into through the fantastic things that we've been learning about and discussing today. So once again, thank you, and over to you, Catherine.
Yeah, thank you, Victoria, for your great job moderating this, and to all the panelists. With so many of these webinars, it's as if we could probably chat for a few more hours about this and hear different people's contributions if we could get the audience to come on live. We've got 3 more minutes if each of the panelists would like to give a short closing remark, starting with you, Julian, and then Peach, and then Joy and Laura. Just 30 seconds to close this out, and remind you again about the survey for the participants, please.
So remember that, thank you, Catherine. Remember the treasures in your community. Everyone has got treasures in their community. That's the wonderful people and places where social capital, where community togetherness and belonging happens. And you can ask yourself, do you want to live in a map of misery or in a treasure map? And I will map the treasures in my community first.
Thank you.
Well, okay, thank you to have me to let me join in, and I would like to share a bit that I think Thailand got the gift for the compassionate community because we have the public health volunteers who is like the auntie next door who know everyone in their area and like give a care. She have a list of all like bedridden people who is children here and to taking care of that. And I can guarantee that this is a very, very successful health like health care model or something like that.
Thank you.
Thank you.
I'd just like to say that iSupport is one of those tools that we could adopt as a front door to person-centered, palliative-aware dementia care. Because it's practical, we've seen that it can be used at home, we can integrate it into primary health care, it's culturally grounded, and we can measure it. So I would encourage everyone to, participate, pick a leaf, see how you can use whatever component to better manage your patients and yourself.
Thank you for that, Joy. I'll just finish by saying that we don't have to work in silos. So again, that's at the center of community living and living together. also resources that are available, coming together and utilizing what's already out there. The iSupport network is a great example of, implementers from around the world that have come together to make sure these tools are available globally. And then for the caregiver, asking for help and ensuring that you're leveraging on the community supports that is around you. So it's important to remember that we don't have to work in silos, and that's both at the micro and macro level.
Okay, has everyone had a last word? If so, I'm going to end the webinar with a big shout out to everyone for all your great contributions, and look forward to the survey results. All right. Bye, everyone. Thank you.